Hello. Bob Smith, 63-year-old male, was seen today in clinic for a routine follow-up. He presents with a 3-day history of some shortness of breath. He reports that it started around 05:30 in the morning 3 days ago after getting out of bed and gets progressively worse throughout the day. He states that he can't take a deep breath and he gets winded easily at work. The shortness of breath is intermittent throughout the day. At rest, it's around a 3 out of 10. But when walking around or getting in and out of his vehicle, he says it goes up to about a 7 out of 10 in severity. At this point, he needs to sit and take a break from activity. Also, climbing stairs is especially difficult. He stops to catch his breath after 3 steps and describes feeling dizzy and lightheaded, denies any syncopal episodes. In the evening after work, when he's able to sit and rest, he feels less short of breath, though he is very fatigued by this point and usually unable to stay awake after dinner time. He has not taken anything for it, but reports that he's drinking more coffee during the day to stay awake. He is able to lay flat and describes that he's sleeping well at night. He has no history of respiratory illness. So Bob's grandson and his wife did have a bad cold last week, he describes, but that he was asymptomatic and that he has been feeling generally pretty good up until this recent complaint. He does report that he had chills and night sweats last evening, but denies any fever. He also denies cough, any audible wheeze on his breathing, any chest pain or chest tightness, and also denies hemoptysis. He does report a decrease in his appetite, but reports that he is drinking well and trying to stay hydrated. There's no recent ECG on his chart or lab work, but he does report that he's taking his medications as prescribed, but he doesn't check his blood pressure at home and does not recall the last time he followed up with his cardiologist. So Bob is diagnosed with dyslipidemia, for which he's taking Lipitor 40 milligrams per day. Also hypertension, he's on amlodipine 5 milligrams a day. He had a myocardial infarction in 2020 with a PCI, and for that he takes ASA 81 milligrams daily, and he quit smoking about 30 years ago. Bob does have a positive family history for cardiac events. His father and his grandfather both passed away of myocardial infarctions, and his brother on his paternal side has well-controlled hypertension. Bob does live with his wife. They both work full-time. He has been employed for 40 years as a long-haul truck driver. He reports that his alcohol consumption is limited to about 2 to 3 beers per month and is just social, and that there is no recreational drug use. He does state that he does not exercise and that his lifestyle is fairly sedentary at home and at work. So today, Bob's blood pressure was a bit elevated at 152 on 89. His temperature was 36.4 and his heart rate was 107 and regular. His weight today is 121 kilograms. He does have a bit of a distended abdomen as well. He appears well, there's no distress, he is not tripoding, there's no scalene retraction noted, but there is some abdominal muscle use on breathing. His skin is pink, but he does have some dark circles under his eyes. So his resps are easy and regular. His rate is a little bit elevated at 20, but there is no auditory wheezes or difficulty breathing. There's no clubbing to his fingernails. His capillary refill is less than 2 seconds. There is no cyanosis noted. His skin is warm and dry. His cervical lymph nodes are soft but tender on palpation, enlarged to about 2 centimeters bilaterally. His mucous membranes are moist and intact. There is no redness or pain described or noted to his throat. So on percussion of his lung fields, there is dullness noted to the left mid-lobe anteriorly and posteriorly. On auscultation, air entry is clear and adequate throughout the upper and mid fields, anteriorly and bilaterally. But air entry is decreased to the bases bilaterally, and there is some fine crackles noted also. Chest expansion is symmetrical. The trachea is midline. Peripheral pulses are strong. There is no edema noted to his extremities, no signs of fluid overload. S1 and S2 can be auscultated. There's no murmur or extra heart sounds, and his JVP is unremarkable. So in summary, Bob is having a new onset of shortness of breath, which is causing fatigue and some difficulty with his ADLs and work. Physical assessment suggests that there could be a possible respiratory infection, but cardiac involvement should be ruled out firstly. Thank you.